to the Mississippi.
I've been among the mighty
One of our own who has, yeah, you can just turn that. To use one of our own personnel who has a lot of expertise in the area, Captain Joe Schrader from Vancouver Fire, who is the head of the technical rescue team, which is an odd little thing. And this is kind of a deal, standing here and chatting like this. So, all right, Joe, go ahead.
Thank you, Dr. Whitwer. I'm not actually the head of the technical rescue team. I'm on the team and am involved with a lot of the medical stuff with it and writing some protocols that we have now that I was going to share with you guys later on. But anyway, that was the only disclaimer I think that I had to do. So this lecture I've done a few times with our department and a couple other places, and then I sort of refined it for PCEP today. But it's not, it's pre-hospital trauma care, but with a real emphasis on bleeding control, hemorrhage control, pre-hospitally. And I've taken a lot of stuff like that the military uses and the way that they control bleeding, because they're really the leaders in hemorrhage control, now. And I've tried to sort of bridge that into something that worked for us in the field, and how could we take a lot of the information and research and studies that they've done and apply it to what we're doing, here in Clark County. So that's the main emphasis of it. And then since we have recently made some changes to our protocols, I was just going to review those, especially the names, of switching from trauma alert to modified trauma activation and that sort of thing. So this is just kind of what we'll be going over today as far as the objectives. And then afterward, Dr. Whitwer will be going over some case reviews. And there's kind of a natural break about halfway through the lecture. And so that'll be a good time for a break, hopefully. It's weird being up here after 16 years of standing in the back of this room. So don't heckle me too much. But since we have a child in here, I'll switch off of that. So anyway, just kind of an overview of our protocols. We have a goal of a 10-minute scene time, which really can be affected with extrication and packaging and those sorts of things. But our goal is 10 minutes. And transport really should only be delayed, to address a deficiency that we find really in the ABCs. And this is especially for the critical trauma patient. If it's somebody that we have time and they're stable, we can take the time to immobilize them more and that sort of thing. But we really should try to adhere to that goal of 10 minutes, which I know is hard to do. And then treatment, really should just be centered on stabilization of ABCs and immobilization prior to transport. So if we need to C-spine that patient, we do that. We address the airway, breathing, circulation, and then get going, and then we can always reevaluate that on the way in. So full trauma activation, that I think came about November 1st is when we started doing this. So the old, well, I've forgotten the old one. So anyway, full trauma activation. The first section is vital signs and level of consciousness. And I won't read these to you because everybody should be pretty familiar with these. And then we'll talk a bit about a lot of these specific injuries today as well. So, PHTLS is the kind of the governing arm or leader in trauma care pre-hospitally, and so they really set the standards. And with cardiac care and stroke care, we're always talking about evidence-based medicine, and things are always changing and ACLS, whenever they come out with a new standard, we roll it out here in the field pretty quickly. But with trauma, it doesn't seem like that really happens. And PHTLS sets the standards for that within the U.S. and then also internationally. But the changes don't take place quite as often. And within PHTLS, there's a section called Tactical Combat Casualty Care, and that came about in like the mid-90s. And prior to that, the military just sort of used trauma care that wasn't really designed for the combat environment. And then after a couple different incidents, they started to look at it, and they identified the leading causes of preventable battlefield death. There's a lot of things that can't be addressed, but the preventable battlefield death, and the leading causes were obviously hemorrhage was the biggest one, and that made up about 90%, and then airway made up about 8 or 9%, and then tension pneumothorax made up about 1%. So those were the 3 leading causes of preventable battlefield death. And so that was about 96 that there was a paper written on that. But it didn't really make too many changes. And then even in like 2001, tourniquets weren't really available commercially for service members going overseas. And so there was a lot of improvised tourniquets. And then the commercial tourniquets, they were being developed, but they weren't real available until kind of the or about 2005, 2006, basically, is when they became available. Now they're readily available and they're everywhere. And they also found that with wounds, and we'll talk about wound packing today, but there's better ways to address wounds than we had done. Kind of historically, the way we've always controlled bleeding is bigger bleeds get bigger pads, and we just pile these big old gauze pads on top of a wound, like the 10x30 trauma pad that we carry. That's essentially like a diaper, and I've been able to put like over 1 liter of fluid into that thing before it starts leaking out. And when we place that above the wound, on top, really it's just absorbing the blood that's coming out. Our goal is to control bleeding at its source, and so that's where wound packing comes into play. And so that's another thing that came out from the military. And just recently, the White House just started this new initiative called Stop the Bleed, and it's like this campaign for the public to identify exsanguinating hemorrhage and then place tourniquets and packing wounds. And NAEMT recently came out with a class called BCON, which is bleeding control, and these are just for the layperson, but they're teaching tourniquets, and they're doing things that that we're still sort of trying to catch up with, but they're teaching these things to the layperson. There's new equipment that can go on the wall, like next to the AED. That's all bleeding control stuff, tourniquets and wound packing gauze and all of that sort of thing. So we should at least be at the same level as the layperson. So with tactical combat casualty care, tactical emergency casualty care is kind of the civilian arm of that, or version. And so there's 3 phases of care. And there's direct threat care, care under fire, and that's basically self-aid or buddy aid. And that's not something, hopefully, that we're going to be subjected to very often. That's being able, providing care for yourself so that you can get back in the fight, basically. And then there's indirect threat care, tactical field care, and then evacuation care. So those are kind of the 3 phases of battlefield pre-hospital care. And there's very specific things that you do in each one of those phases as you're moving forward. So I can see a relation to with like tactical field care. That's kind of our on-scene care phase, and then there's the evacuation care. That's obviously our transport phase. So in the on-scene phase, we're going to do an initial assessment. XABC is just a memory aid. The X stands for exsanguinating hemorrhage. So that's the first thing that we're going to address. If we see somebody that's got a significant uncontrolled bleed, we're going to try to address that before we move on, and then do A, B, C, D, and E. Our intervention should be centered around stabilizing those ABCs. So as we find a deficiency, we address it, obviously. And again, our target's 10 minutes. And then in the transport phase, we're going to reassess the interventions that we've done. If we've placed a tourniquet, is it working correctly, or do we need to place a second one? This is when we can bandage those wounds, you know, splinting the injuries, that sort of thing. Getting on definitive airway control if we've placed a basic airway. Once we get into the transport phase, that's when we're going to address, do an ALS airway. And then prevention of hypothermia. There's a lot of research that really has been around for a while, but just on hypothermia prevention, you know, what hypothermia does to a trauma patient. And it really has a very negative effect on them down the road, you know, even once they get to the hospital and they've been resuscitated with blood products and with heat. What we do in the field makes a really big difference. So, you know, getting on top of that, I know when we have a trauma patient and I'm in my turnouts, and as soon as we get into the back of the ambulance, I strip off my coat, and then I usually reach up and hit the lights and the AC because I'm hot, you know, but that's not good for the patient, you know, because we want to keep those patients warm. We should be sweating, you know, and covering them with blankets. So getting on top of the hypothermia early, obviously the best treatment of it is just preventing it from happening because it's difficult to deal with. And then vascular access and fluid resuscitation when it's needed, and pain management, and then splinting. These are kind of all our goals during transport. So the XABC assessment, exsanguinating hemorrhage, that's where you know, we're going to place a tourniquet. We're going to identify this bleed and put a tourniquet on. When I became an EMT, I was taught, you know, elevation or direct pressure, elevation, and then pressure points, and then add more gauze. And you know, it was this kind of long thing. You never took off gauze. You just always added more. And then if everything else didn't work, then you considered a tourniquet, but it was highly discouraged. And by that time, this person had bled out for the most part, and if we were going to be putting on a tourniquet. And then you had to kind of gather your stuff, you know, a cravat, and find a stick that's not going to break. And so really a lot of the research has just moved the tourniquet up really high. So if this is an obvious exsanguinating hemorrhage, it's something that we need to control the bleeding on, and direct pressure doesn't work immediately, we're going to go straight to the tourniquet rather than addressing or trying to deal with it in the other way. And then wound packing for junctional wounds, we'll talk more about the specifics on that. Airway, you know, the NPA is an excellent airway to use. It's very simple. You can place it on a semi-conscious patient or even conscious. Most of the time I teach trauma class. As I'm teaching this part, I slip an NPA in and keep talking for a little while, just to show that it's really a very non-invasive airway. It does sting a little bit, but and you know, it kind of got a bad rap, it seems like, in trauma care and head injuries, because you know, I was taught that when you place an NPA in somebody that has a head injury, you know, the chances of it going into the brain are really high, and that, based on research and studies, you know, that's just not really true. You know, I think that's been overstated. And as long as you place the airway correctly, you know, and follow the nasopharynx, and you're not placing on somebody with like a Lefort 2 or Lefort 3 fracture, you know, major facial trauma, it should be an effective airway. In the military, the NPA is used. It's kind of the standard airway, you know, as the first line. And then for breathing, we're going to place, you know, chest seals, any holes that we find. Obviously, we're gonna cover those holes. Needle decompression for tension pneumothorax, and then making sure the patient's oxygenating well and ventilating well. Circulation. This is where we're going to address all of our bleeding, not just the exsanguinating hemorrhage. If we placed a tourniquet, this is where we're going to, you know, now we're going to bandage that wound up, and then abdominal seals for like an abdominal evisceration. Eye injuries and burns, that's kind of the phase that we deal with that. And then for disability neurological assessment, AFPU and GCS, and then, you know, we're going to immobilize the spine completely. If we have obvious indications for spinal immobilization, you know, we start protecting it during kind of the airway, but we're going to address it, you know, when we get down to that level. And then exposure, environmental control, obviously exposing the patient, but now we need to cover them up and keep them warm. Trauma patients don't thermoregulate well, so we need to do it for them. So with exsanguinating hemorrhage, typically, you know, with our head-to-toe blood sweep, we can do this visually as we're walking up to the patient. You know, we're seeing them laying in a pool of blood or squirting blood out of a hole somewhere. But, you know, low light situations or you know, doing a rapid blood sweep just really quickly to try to find the major bleeding and address it quickly is a good idea. Stopping major bleeds, you know, it really is well-aimed direct pressure, not just direct pressure over the wound, but well-aimed. And if you have a large wound cavity or wound bowl, that's going to involve placing gauze into the wound to really control bleeding at its source. If direct pressure doesn't work, then you know, you can attempt a pressure dressing or placing a tourniquet. And then you can move on and deal with the next injury. So with tourniquets, is just a little bit of information about them. You know, PHTLS and the American College of Surgeons recommend tourniquet placement to control bleeding anytime direct pressure doesn't immediately control the bleeding. And tourniquets really have little to no risk if they're in place for under 2 hours. There's some studies in like prolonged field care in the military where tourniquets have been on for 6 hours and just had limited nerve damage and tissue damage. But obviously, life over limb, we're going to place that tourniquet. And here, at least, you know, kind of in the core of Clark County, that's really not going to be an issue. We should always be at the hospital in that under 2 hour mark. You know, I've definitely, when I worked North Country, definitely had some longer transports where that may have been an issue, like on the mountain, but and same with Camas. But for the most part, it really shouldn't be a big deal. We want to place the tourniquet high on the extremity above the joint. The benefit of that is, you know, the higher up on the extremities, you have one blood vessel that's very large, and it's running close to the surface along one bone. And so it's a lot easier to tamponade than like down in the forearm or the lower leg, where you have two bones, you have multiple arteries, and they're deeper. And, you know, since it doesn't cause a lot of tissue or nerve damage, going high is not a problem. So it's a lot easier. You're going to be more successful going high on the joint. There's a lot of tourniquets out there. There's probably, you know, 10 very popular ones on the market. The tourniquet that we carry is the CAT tourniquet, combat application tourniquet. And it's definitely the most prevalent one that's out there, and the one that everybody sees the most, you know. And it does have some downsides to it. It's very painful because as you tighten it, it kind of sucks tissue up into the buckle. But it's also very effective, and it has kind of a high failure rate. But when you look at that based on how much it's been used, you know, it's still a very effective tourniquet. But one of the big things that's going to make you successful when you place one of those tourniquets is removing all of the slack out of it before you start to tighten it down. That's probably the biggest cause of tourniquet failure or it just being ineffective is when there's still a little slack in there, because as you tighten that bar down, it only has, you know, 3 or 4 turns in it, and so if it still has slack in it, it's just not going to be quite as effective. Always leave it visible, obviously, and we still mark it. We don't got to do the bloody T on the forehead anymore. There's a nice little white tag on the tourniquet that you can put your time, write it on there. And then if a second tourniquet is needed, you can place one. And with leg wounds, femoral artery wounds, upwards of like 50% of those require 2 tourniquets to get effective bleeding control. So with that, you just want to put that second tourniquet nice and close to the first one. So you're essentially getting like a 3-inch tourniquet, you know. So that coverage, surface area is what makes it more successful. They're incredibly painful. I've had a lot of them put on me in training, and definitely have felt how that skin sucking up into the buckle is very painful. So, you know, be ready to provide pain management. If we have a patient that, you know, has a traumatic amputation of the arm and with an obvious arterial bleeding, we place a tourniquet on that arm, we've essentially removed that injury from the patient's vascular system, you know, and so now they're essentially stable and we can address their pain and not be worrying about affecting, you know, their blood pressure. It's not an uncontrolled hemorrhage anymore, if that makes sense. So getting on top of that pain management early is a good thing. And then we're going to bandage the wound. bandage the wound. So this is a improvised tourniquets, prior to, the current conflicts. There really weren't very good tourniquets on the market. So improvised tourniquets really involve just cravats and with a stick and trying to tighten that thing down tight enough to get effective bleeding control. And there's a lot of people that have lost their lives because there just weren't really effective tourniquets. And one of the problems was the width of the tourniquet. A lot of times it was too narrow. Using a shoelace or something obviously is not going to be a real effective tourniquet. In Boston, when there was the bombing there was, I believe, 17 or 18 traumatic amputations, and there was about somewhere around 25 people that had identified exsanguination on scene from an extremity wound, and there was about 27 tourniquets that were placed on scene. None of them were commercially made tourniquets, so they were all improvised, and none of those patients lost their lives. The 3 people that died instantly on scene, and so they were all effective tourniquets. But what came out of that is that there was some tissue damage and nerve damage, and so there was a study that was done. They started collecting data right away, and they found that there were some problems with those tourniquets that were placed, but they also found that was because they were all improvised tourniquets, so they weren't working as effectively. And the big conclusion that came out of that study is that every pre-hospital service in the U.S. needs to have commercially made tourniquets available for their providers to use. I have a good friend that's a paramedic in Boston. He was actually there, and he said that the injuries were, the wounding patterns that they saw were obviously different than anything that they had ever seen. They were, battlefield injuries, and the ability to control that bleeding was really difficult, just because of the trauma that was done. So they've obviously revamped their bleeding control since then and are a lot more prepared for it. So with wound packing, this is well-aimed direct pressure. With junctional wounds like the axillary area, the inguinal area, that's kind of a non-compressible area. It's difficult to control bleeding there. Obviously, you can't get a tourniquet on, up in the neck, even if you might want to. So you have to control the bleeding in a different way. And if you have a large wound cavity or a wound bowl there, where there's a bleeding vessel within that injury, but it's difficult to visualize, just placing gauze on top of it it's going to be hard to control the bleeding that way. So what we want to do is fill that wound cavity with gauze and control the bleeding, basically from the inside working out, and then put pressure on top of that. And the gauze that we carry at the Vancouver Fire Department it's basically like Kerlix. It's not combat gauze, which is impregnated with like a hemostatic agent. That stuff's available, and I believe that Dr. Whitwer approves of it, but it's cost prohibitive somewhat. I'm getting a nod, yes. So it's a difference of about $2 or $3 for a pack versus like $40. So it's just a lot more expensive. But there's a lot of really effective stuff on the market now. It's not cauterizing the wound and causing local tissue damage when you put that stuff on. And there's some good stuff that's, I think, in the next couple of years, it's just going to be so available that I'll bring down the cost. So when we pack a wound and we have arterial bleeding, what we want to do after we fill that cavity with gauze is place really good firm pressure on it for 3 minutes to really try to give that wound the ability to begin to form a clot before we bandage it with a compression bandage. And I've already said this, but with bleeding, all bleeding has a source and a name. There's a blood vessel that's causing that bleeding. So we want to try to address that bleeding at that vessel as best that we can before we move on. The trunk, the chest and the abdomen, it's a large compartment, and it's difficult to control bleeding in the chest, especially if the blood vessel is not like in the chest wall. So we're not just going to blindly pack a hole in the chest with gauze and just, oh, give me another one, keep going, you know. But if it's bleeding within the chest wall, I'm doing that. Then we can pack those wounds if we need to. There's a couple new pieces of equipment on the market for non-compressible wounds, pelvic injuries, abdominal injuries, and exsanguination in the lower limbs. There's the abdominal and aortic junctional tourniquet, and then there's also the pelvic hemostatic belt, and there's a few others. Sam Splint has developed one, and basically it's just a large belt that you place over the patient, and then you inflate this large bladder that sort of just goes down into the abdomen and tamponades the aorta. And from studies that I've read, like from pig labs, and they look very effective, but they're very expensive. They're about $600–700 for one of them. So these are the two different types of wound packing gauze that we carry at Vancouver. There's the S-rolled gauze and Z-pack dressing, and really the only difference is the way that they were folded. One is in the shape of an S, and the other is in the shape of a Z. So they're kind of interchangeable in our trauma kits, and it's just Kerlix that's 4.5 inches wide by just over 4 yards. And so you open up the package, and then you have just this tail of gauze that you can start to pack into the wound, feeding it in, and then the package keeps it clean. You can do that with like a roll of Kerlix, but it's going to be more difficult, you know. And if you have Kerlix, what you can do is just sort of grab that the end of the gauze that's in the very center of the roll and kind of pull that out, and you can start feeding it in that way. And that's a different way to do it if you're not carrying the specific stuff. With airway management, the progression of airway management is, you know, we're going to evaluate the airway, open and clear it of any obstructions, and then we're going to try to protect it, keep it open. Always plan for failure and have a backup plan. You know, if what we do isn't working, then what's the next thing that we're going to go on to, you know? And, you know, having that, the surgical crike kind of back there in the back of your mind. Hardest part about doing a surgical crike is just deciding to do it. You know, once you kind of get over that part, it's really not that difficult of a procedure. If we aren't dealing with C-spine injury, the best position for these patients is, you know, sitting up and leaning forward so that they can kind of clear their airway naturally and assist with that. And then we're going to reassess the airway every time we move our patients. You know, our tube placement, is it still in the right place? You know, and making sure that we're not losing our airway. And a good memory aid for that is DOPE, if you're not familiar with that. Just displacement of the tube obstruction, pneumothorax, and then equipment failure. And that's a good kind of way to work through the problems and try to identify what might be going on. Breathing, we're going to assess the rate, quality, and depth of breathing. Injuries that, you know, can really have an effect on that are a pneumothorax, hemothorax, and then flailed chest. If we have a patient with significant rib injuries, they're going to be guarding, and they're not going to be ventilating as well, and oxygenating as well. So, you know, giving those patients pain management early on is really going to help their breathing, because we're going to decrease their pain and help them to breathe more comfortably. The treatment for that for airway injuries, obviously, is to begin with assessing it, and then just assuring adequate ventilation and oxygenation. Covering holes with occlusive dressings. If we find a hole, cover it. Always look for an exit wound. And then needle decompression for tension pneumothorax. With pneumos, you know, we used to carry the large Cook pneumothorax kit, and it was very expensive, and it had a lot of working parts that you had to put together. And now PHTLS recommends that you just place a needle and you leave it an open hub, so we're not putting on a 3-way stopcock or a 1-way valve. We're just placing the needle, and essentially we're just converting it from a tension pneumo to a simple pneumo. And the reality is, you know, we're using a 14-gauge needle, and it's going to clog up with blood or tissue or something else pretty quickly. So it's not a lumen that's staying open for the most part. And I've had to try to clear those before during a longer transport, and then even do a second decompression right next to the first one. So, it's really just you're clearing that you're relieving that pressure, but that needle is not staying open, basically. And so that there was some studies that were done, and the recommendation is a 14 gauge needle that's at least 3 1/4 inches long. Using our IV angiocaths just aren't long enough to make it into the pleural space on a lot of patients. So having that length is going to make you more successful. Remember, we don't bury the needle all the way to the hub. Once we get into that pleural space and we get confirmation that we are there, then we're going to slide the catheter off the needle. And then if the patient is unconscious, we want to have them C-spined, and if we can elevate the head a little bit. And then if they're conscious, sitting up or a position of comfort is probably going to be the best thing. With circulation, we're going to reassess and control all bleeding. Our goal is to save red blood cells. I think the biggest take-home that you can have with trauma is just save red blood cells. Every one of those blood cells it's important. And even if it's venous bleeding, that blood cell is going to come back through the heart and become reoxygenated. So we really need to just save red blood cells. And if that's your goal, then addressing all bleeding is important, And so we're not going to let somebody continue to bleed until we get them into the ambulance and then deal with it then. We want to be aggressive with bleeding control. Well-aimed direct pressure, compression bandages, and then wound packing. Obvious vital signs, blood pressure, we're going to do, I'm going to talk a little bit about mean arterial pressure a little bit later, and what that is. And then start IVs, fluid boluses for hypovolemic patients. Our target blood pressure for hypovolemia is 90. And with head injuries, we want to keep that blood pressure a little higher. Test question. And it's going to be about 110 systolic for the head injured patient. And then 2 large bore IVs wide open is no longer the standard of care for trauma patients. When I first became a paramedic, I felt pretty awesome if I picked up a patient like Grand and Fourth Plane and got 1.5 liters into him before I made it to the hospital. I thought I had just done really good. And there's a lot of research that's showing that prophylactic fluids, high volume fluid resuscitation is not helpful for patients. And we're going to talk about that more later. But that obviously is kind of old information, but it still happens from time to time. So we really need to be careful with given fluids. Beyond just the Kerlix gauze rolls that we carry, we also carry elastic bandages like an ACE wrap. These work awesome for head injuries. When we wrap up a head with gauze, a lot of times we make it look really nice, and then all of a sudden it just cones off of them. And these ACE wraps work really good at just staying in place. We carry a 3-inch and then a 6-inch wide by like 5 yards, and we have those in our trauma kits. And then also it's a very effective compression bandage. If you've done wound packing or you take an ab pad and then you wrap it up with the elastic bandage, it's really effective. And then there's the emergency bandage, which is more commonly called the Israeli bandage. And it's a really good commercially made compression bandage that has a large gauze pad attached to it. And then it also has a pressure applicator bar and a closure bar. So it's just got a few things added to it. There's a bunch of different compression bandages on the market. And I bought every single one of them that I could find when we were demoing them and just played with them. And the benefit of the Israeli bandage is it's simple enough to put on when you're under duress. But it's also complex enough that it's going to do a really good job controlling bleeding. So it's 6 inches wide, and it's very stretchy, and then it's got a large gauze pad on it and with a pressure bar. And there's a couple other pictures later on in the slides. One thing that I forgot to talk about is with chest injuries, I may have just skipped it, but we used to be taught to take something that was occlusive and place it over that hole and then tape 3 sides. And that's kind of old information. It's really difficult to make an effective occlusive dressing because of, you know, the thickness of packaging and stiffness and everything else. So, and there's a lot of really good occlusive dressings that are on the market now. The one we carry is the Asherman chest seal. That's a vented seal. And then I've made the recommendation that we start buying the Hyphen vented seal, which I think is a really good chest seal. It's a newer one on the market, but it has a really good performance in different studies. A lot of the information on this stuff is kind of empirical data. They're, you know, asking combat medics and people that are doing this every day, you know, what's working for you in the field. I did my own little, I kind of geek out on trauma, and I bought a couple different chest seals and then slapped them on and got on the treadmill. And when I started sweating, you know, some of them just right away separated from the skin. So the big thing is just how sticky it is. And the Asherman, it's a good seal, but it's not, it doesn't have real good adhesion, so it will separate from the skin. You know, if you have a bloody, sweaty, hairy patient, you know, it's difficult to make a good contact. Really, I think the best chest seal out there is a defib pad. You know, just take the defib pad, cut the wires off, and slap it on, and it's going to stay in place really well. And if you have a patient that's starting to develop what you think, you know, they might be developing a tension pneumothorax, then you can just go ahead and burp that pad, you know, and obviously you want to do that on exhalation, and then you can reseal it. And then the way that we're going to manage it at the ALS level is by chest decompression. But that's a really good seal. I've used it a few times. It's not vented, but it's an effective way to control bleeding. It's something that we carry. With disability neurologic assessment, we're going to evaluate AVPU and GCS, and then if we have signs of a cervical spine injury, then we obviously need to address that with full spinal precautions. I believe the only couple of times that I've had the privilege of visiting Dr. Whitwer and Mark have been not C-spining patients that I probably should have. So, you know, if there is that indication there, then do it. And then assess for head injury. Exposure environmental control. Want to expose our patients for a detailed physical exam, make sure we're not missing any injuries. You know, with penetrating trauma, it's easy to miss injuries, especially like in the axillary area. And you know, always looking for the exit wound with any injury, though. Obviously, we want to expose the patient. And then we want to right away start preventing hypothermia, and that just involves, you know, getting the patient up off the wet ground, you know, covering them with blankets. You can use hot packs in the junctional areas to help warm, and then ambient rewarming in the ambulance. You know, hypothermia increases the risk of coagulopathy. You know, the colder a patient gets, the more difficult time that they have of forming blood clots in the trauma patient. Our risk factors, you know, are age, fatigue, alcohol use, which is a common thing, and then dehydration and injuries. You know, all those. When you have a patient that's injured and they're even in compensated shock, they have a more difficult time of thermoregulating. So we need to be more aggressive with preventing that hypothermia. And then I already talked about the treatment of that. And then treatment during extrication. This is something that I've kind of worked on for a while, and you know, Google it and trying to find what is kind of the appropriate level of care for a patient during extrication. And there really wasn't much information out there. And I definitely think that really good, high quality extrication techniques is good patient care, because we're getting those patients out of the vehicle. And we do a really good job of extrication most of the time, and getting really aggressive. But sometimes we get so focused on that we forget about the patient that's inside the car, and we think once we get this patient out, that's when we'll start providing good patient care. And we need to be, you know, doing that while the patient is still trapped. Being that patient's advocate, you know, identifying somebody as the, you know, the rescuer that's going to do patient care, having them get inside the vehicle to reassure the patient, be their advocate, and then communicate between the patient and the extrication team. and address, you know, any deficiency in the ABCs that we find before we get that patient out. If you have somebody that is bleeding just even from a moderate wound, if they bleed over the course of 10 or 15 minutes while we're working to extricate them, they could, in that amount of time, lose over a liter of blood very easily. So we need to address that bleeding before we remove the patient from the vehicle, and that really only takes a few minutes. And then, you know, consider pain management or sedation if it's needed for a long-term extrication or very painful. You know, we're unwrapping the foot from the brake pedal, things like that. So this is kind of something that I just came up with that I've done on patients. You know, if I'm arriving first, you know, that the MPA is a great airway for your patients that are unconscious or semi-conscious. And then placing the C-collar, those two things are going to really control the airway, keep it open, working together. And then you can, if you're limited with hands and you don't want to go hands-on yet, you can tape their head to the headrest on the seat, and that'll kind of keep them in the upright position, leave the seatbelt on, obviously. If you have bleeding, you know, from a leg wound, like an open tib fib, and this extrication is going to take 10 or 15 minutes. If you can't access that wound, then the placement of a tourniquet would be appropriate. And our protocols say that once a tourniquet's placed, that it needs to remain in place until the patient gets definitive care. But this is something that I've checked with Dr. Whitwer on. I gave Dr. Whitwer this PowerPoint and every concept that I could think of that I was going to teach today, so hopefully he would approve it and not have to interrupt me during the lecture. But there is that chance that I may say something that is a little too... He's waiting for the break. In that situation, though, if we have somebody that we're just needing to control bleeding temporarily until we can really access that wound and effectively control the bleeding, placing a tourniquet would be appropriate. And then once we've extricated the patient, we could try to address that bleeding you know, with a compression bandage, and in that situation, we could remove the tourniquet. Another example would be if law enforcement places a tourniquet or a civilian before we arrive. If we feel like we can control that bleeding, then that would be another situation where you could loosen the tourniquet. If it's significant bleeding, leave the tourniquet in place, just loosen it, and that way you can tighten it up if you need to. But the CAT tourniquet is what pretty much all law enforcement in this area carries. CCSO, VPD, most departments, the officers have one. They've had one issued to them. And then same with the Israeli bandage. That was another reason why we went with it, is because law enforcement is familiar with that bandage. So, you know, that's something where you could just toss to an officer and they would know how to place it likely. So getting to the transport phase, you know, we're going to reassess our on-scene interventions, airway, breathing, you know, our bleeding control. And then this is where we're going to do our definitive airway control if we need to, a detailed head-to-toe exam, and then vascular access. You know, our target BP, again, is 90 systolic, 110 in head injuries. And then fluid challenge for hemodynamically unstable patients to reverse shock. That's when we're giving our fluid bolus, is if they're showing signs of shock or they're headed in that direction. But if they have a stable, acceptable blood pressure and heart rate, then we're not going to just bolus them with lots of fluids. You know, the problem with our fluid that we carry, the crystalloid, it doesn't transport oxygen, and it's cold, even in the summer, kept in our kits, compared to the core temperature of our patient. That fluid is cold, so it's going to increase the risks of coagulopathy and also of hypothermia. With pain management, you know, fentanyl's our pain med. It's a lot more cardiostable than morphine was. Its effects on lowering the blood pressure, you know, just aren't as huge as morphine. And, you know, it's short-acting, and doing good pain management in the field is associated with better patient outcomes. So there's been several studies that have shown that when we provide pain management in the field, that patient's recovery is shorter, and like their hospital stay, and then overall amount of pain medicine that patient requires after surgery and during the recovery phase is less. So what we're doing in the field has a big impact on that patient long term. And then splinting extremities and then preventing shock. With head injuries are the leading cause of trauma deaths in the U.S., civilian deaths, not the leading cause of preventable death, trauma death. But a history of a loss of consciousness is very important to have and then relay that to the hospital staff once we get there, even if it's a very short, transient period of loss of consciousness. We're going to assess AVPU and GCS and then consider intubation RSI. With head injuries, we want to maintain their CO2 a little level between 30 and 35, a little lower rather, and if the patient has signs of intracranial pressure. And then our target BP again is 110 systolic. Our SpO2 goal is about 95%. You can consider elevating the head, even if the patient's on a backboard. And then only hyperventilate these patients if they're showing signs of brain herniation. That's the only time we're going to hyperventilate. With severe facial trauma, consider a surgical airway if you're unable to intubate or ventilate the patient. Burn injuries, this is just a quick overview of burn depth, 1st degree, 2nd degree, 3rd, and then 4th degree. 4th degree involves all the layers of skin, tissue, down into the bone. It's a pretty catastrophic burn. And the burns that we're really concerned about are 2nd and 3rd degree burns. The rule of 9s, everybody's pretty familiar with those, I'm sure. And then the rule of palms, just remember it's the patient's open hand, not your hand. And that accounts for about 1% of body surface area. For treatment, obviously we want to stop the burning process first, and then airway and breathing. If there's signs of inhalation burn, we want to get aggressive with that early on. Estimate the percentage of burns, and then initiate IV fluids. Our initial bolus, really in the field, our fluids should be about 500 cc's per hour. But if you're going more long-term, coming down from North Country or Camas, then there's the Parkland burn formula. But that's really for the hospital, kind of longer term. So 500 cc's per hour is a good rule of thumb. Remove all clothing and cover the patient with burn sheet. One of the biggest things with burns is air passing over those exposed nerve endings. And so wrapping that patient up in a burn sheet will really help decrease that person's level of pain. Fentanyl is a great thing for burns, and you can chase it with a little Zofran if there's nausea involved. And then critical burns, those are the ones that we're going to want to divert to the Oregon Burn Center if we can, and get the patient down there. I'm on a federal disaster team, and what we use for burn care is just saran wrap. We just wrap the patient in saran wrap, and we'll put on different burn creams on the patient sometimes, but just wrapping them with the saran wrap is sort of the best treatment that we can do. And the way that most of those plastic wraps are made, they're heated to a level that they're basically sterile once you get past that first outer roll. So we'll just wrap those patients up with those. Not approved yet, though, in the field here. With RSI, this is just a quick overview of RSI, with the need of definitive airway control in a patient that has a gag reflex. Our pre-treatment medications are going to be lidocaine for suspected increased intracranial pressure, our head-injured patients. Atropine for any adult with a heart rate under 100 or history of hypoxia, and then all children under 12. Etomidate up to a maximum of 20 milligrams. An alternative medication for RSI is ketamine, and I don't think some kits still have ketamine in them, some of them don't. Ketamine's a really good RSI medication, pre-medication for pediatrics though, and then also airway problems. And then another alternative would be Versed, what we've used. And then succinylcholine is our paralytic at 1.5 milligrams per kilogram. Want to maintain our end-tidal CO2 between 35 and 45 with the head-injured patients. Again, we're going to try to keep that a little bit lower and allow their blood pressure to be a little higher. With pain management, fentanyl's are our drug that we carry, drug of choice, and 25 to 50 milligram increments, give it IV, IM, or IO to a maximum of 200 micrograms per hour. Pediatrics we can give nasally, the fentanyl. And you know, fentanyl has a really wide safety margin. It's very short acting, very effective drug, and but it still can exacerbate hypotension in a hypovolemic patient, so we have to use it carefully in those situations. And then, you know, I already talked about the, you know, long-term outcomes of using pain management pre-hospitally. So let's, it's 10 o'clock, and this is sort of that natural break, so let's take a 10-minute break, and then if we can get going about 10:10. So I got some good feedback at the break that I might be talking a little bit too fast, so I apologize. I know there's that balance of wanting to get done quick and you know, getting good information, so I'll slow it down a little bit. No, please don't. So this, we're going to kind of go more into you know, how to manage these trauma patients. You know, we've addressed the injuries the best that we can, and this is just something that I've worked on for quite a while, just really on hypovolemic shock and what we can do in the field to improve these patients' outcomes, even if it's, you know, a short 10-minute transport or a longer transport. And you know, a lot of this has kind of come from my experience when I worked at North Country and having these long transports and seeing my patients deteriorate and wondering what I was doing wrong, and then also from the disaster team I'm on, I've had the opportunity to deploy to like Haiti after the earthquake, and just seeing the injuries down there and the trauma and shock, and you know, and how those patients progressed, you know, and so I kind of tried to put that together, you know, how can it apply to what we do here. So hypovolemic shock, you know, if we strip it down to a real basic level, it's global tissue hypoxia secondary to hypoperfusion. You know, the heart is not effectively pumping blood for one reason or another, oxygenated blood enough to the tissues to make up for the ATP demand. ATP is kind of a currency unit that the body uses, you know, and the muscles use for perfusion and energy production. And when there's a deficiency in that, the body can compensate for a period of time, but if we don't address the problem, then there's a cascading effect that begins. And kind of like with everything else, what we do pre-hospitally has a big impact on the patient's outcome long term. So, for adequate perfusion, the heart needs to be working properly. Blood vessels need to have proper tone, be able to constrict and dilate as needed, and adequate blood volume delivering oxygen. Losing 1/5 or more of your normal blood volume will cause hypovolemic shock. Excuse me. And if it's not addressed, then that's going to progress into more severe shock that is harder for us to deal with. So, when ATP demand outweighs ATP supply, you know, the muscles begin to produce lactic acid, and that builds up, and then it's very inefficient, and so the body switches to anaerobic metabolism and is demanding more oxygen, more energy than the body is able to supply, and that's where shock develops. And it's a cascading effect that is going to lead to cellular death, and then we're not going to be able to deal with it. The different states of shock, there's compensated shock, loss of 20% or less of blood volume. The body's still able to compensate for that deficiency in blood volume temporarily, and if there's a deficiency in one or more of those areas of perfusion. So a significant mechanism of injury associated with, or along with tachypnea, tachycardia, pale, cool skin, restlessness, and a systolic BP of greater than 90 or a MAP of greater than 60, that would be compensated shock. When the patient goes into decompensated shock, that's typically a loss of 30 to 40% of blood volume, and the compensatory mechanisms are beginning to fail. They're unable to keep up with this deficiency in the body. And that's a clinical picture of shock along with the systolic blood pressure that's dropped below 90 or a MAP below 60. Again, we'll talk about MAP, what that is, if you're not familiar with it. And then irreversible shock, that's the lethal exsanguination, and where the patient has bled out. If it's internal bleeding, then there's not a lot that we can do about that if it's a significant bleed. And body's compensatory mechanisms completely fail, and there's really nothing you can do about that. So mean arterial pressure is something that we don't really utilize in the field very much. In the hospital, it's become very popular and is used quite a bit, especially with septic patients and then in critical care like the ICU. And what mean arterial pressure is it's the average arterial pressure in the vascular system during one cardiac cycle. And it's a good indication of how well this patient is perfusing their vital organs. And the equation for it is 2 times the diastolic plus the systolic divided by 3. And that gives you your MAP. And that's not something that I can do even when I'm calm doing that math equation. But conveniently, our LifePak 12s and our 15s provide us with the MAP every time we do a cycle of vital signs on our patients. And so this number down here, I always kind of thought that number was just sort of the average between the systolic and the diastolic, and I never really put much thought into it. But that's actually the MAP, and that's a number that's provided for us. We don't have to do anything special. When we take a blood pressure, it shows us what the MAP is. The normal mean arterial pressure of an adult patient is between 70 and 110. We don't want the MAP to get below 65 because the patient is not perfusing well. And then below 60, the heart and kidneys and brain are no longer being perfused adequately. So that below 60 is clinical signs of decompensating shock. And this is, the hospital is using it a lot now. I think in the future for us, the MAP is going to become a tool that we utilize a lot more. And then also with end-tidal CO2, that's going to become, we are already using that, but in the hospital, that's becoming, a real specific diagnostic tool for trauma patients as well. How well are they perfusing? And so it's pretty basic. You don't need to know too much about it. Just try to keep it above 65 and certainly above 60. And with the MAP, it's a good tool for us to use for adult trauma patients, not for pediatrics though. With pediatrics, the blood pressure is affected so much by if it's a male or female, how tall they are, the way that they compensate for a shortfall in perfusion. So it's just not as accurate of an assessment tool in peds. But for adults, it's a really good tool for us to use. And if you can convey that over the radio, in your HEAR report, what the MAP is, the hospital is going to be interested in that, and that's information that they can really use to come up with kind of the course of the treatment. So our treatment of shock, we really want to prevent and reverse hypoxia and hypoperfusion, get adequate airway control on these patients, and we want them to ventilate them with 100% oxygen. When we're in the resuscitation phase with a trauma patient, it's really important to make sure that they're adequately oxygenated. If we're not resuscitating them and they're very stable, then we're a little more concerned about over-oxygenation. But in a patient that's in showing signs, clinical signs of shock, we really want to make sure that they're adequately oxygenated. And then identify all hemorrhage and control it if we can. If it's external hemorrhaging, save red blood cells, every one of those. and then establish an IV or IO with normal saline. Fluid boluses for hypovolemic patients to reverse shock and maintain body heat. Most literature, including PHTLS and ATLS, recommends hypotensive resuscitation. That's another term for that is permissive hypotension, and that's something that we're allowing that patient to be a little more hypotensive than normal if we can't control their bleeding until they can get to definitive care and address that hemorrhage. A normal mechanism that your body has when you begin bleeding is your blood pressure drops, and that triggers the liver to release enzymes that have clotting factors, and so they go and they start to produce blood clots. And when we prophylactically or artificially increase that blood pressure with a large fluid bolus, that kind of tells the liver that bleeding is controlled and the blood pressure has returned to normal, and that it doesn't need to release those clotting factors anymore. So when we're artificially increasing the blood pressure with normal saline, when it's not needed, when we're not resuscitating these patients, then we can actually kind of cause more problems that weren't intended to cause. So our target blood pressure again is 90. With hypotensive resuscitation, it's just the restriction of fluid administration until that hemorrhaging is controlled. If it's an extremity hemorrhage, we're bandaging it and we're addressing it that way. If it's internal bleeding, then we're hauling butt to the hospital and getting them in there so that they can have that bleeding controlled surgically. It's really only useful in the first hour following a traumatic injury, so it's not something that we're doing long term. We don't use it for head injured patients, burn patients, pediatrics, again, because of the way that they compensate for deficiency in perfusion. So it's really just for hypovolemic shock, from penetrating or blunt trauma. And I think we've already talked about the blood pressure several times, so I'll pass on. The lethal trauma triad, that's acidosis, coagulopathy, and hypothermia. And those things all kind of go hand in hand, and they really affect each other. So when we have a patient, a trauma patient, they've sustained an injury and they're not perfusing adequately, that oxygen demand within the muscles outweighs production, and so they start to develop more lactic acid, and that leads to acidosis. And then with coagulopathy, continued massive exsanguination, and then the body's ongoing attempts to control that bleeding depletes the body's clotting factors, and so that leads to coagulopathy. Or if we give large volumes of normal saline, that thins the blood, and that leads to coagulopathy as well. And then hypothermia, it exacerbates coagulopathy. It also decreases the body's ability to form blood clots and increases ATP consumption because the body is trying to thermoregulate, trying to increase that core temperature, and so that's using up energy as well. And then it also leads to patient discomfort. So our treatment really is to maximize oxygen delivery throughout the body for these patients. Keep the patient warm. We should be sweating during transport, and then minimize IV fluids unless they're needed, a fluid bolus to reverse those signs of shock. So hemorrhagic shock and the lethal trauma triad, they really go hand in hand, and it's a cascading effect. So one thing affects the other, and it just snowballs and gets worse and worse. So if we can prevent that from occurring early on, it's going to have a better outcome. It's hard to catch up with. So with damage control resuscitation, that's a term that kind of covers a few different things. In the field, what we're doing is the permissive hypotension or the hypotensive resuscitation. In the emergency room, what they're doing is hemostatic resuscitation, giving blood products and clotting products that promote clotting, and then damage control surgery early on, and that's just real, focused initial surgery to address the injuries, the bleeding, and then and control that bleeding, try to stabilize the patient. Sometimes patients will go in surgery, get these wounds, the bleeding controlled, and then 24 hours later, maybe they're going to go back into the operating room and have these wounds actually addressed. But initially, it's just to control the bleeding. With the damage control resuscitation steps, obviously stop the bleeding first, and then prevent hypothermia, hypotensive resuscitation. Don't pop the clot. When we jack up that blood pressure really high, that's putting a bunch of pressure against this really fragile blood clot, and that increases the risk of that thing bleeding again, and internally especially, where we're not able to compress that wound at all. When we increase that blood pressure, it puts more pressure on that blood clot. It starts on scene. We want to deliver these patients to the hospital ready for definitive care. So if we can, with trauma care, look at pre-hospital care as pre-surgical care, what can we do in the field, and during transport to make these patients as ready for definitive care as possible. That's really going to help their outcome long term. Any questions so far? Good. I was hopeful that the phone would not be working today. That always stressed me out when people would call in, Thought about that today. All of my supportive friends out there. We talked already about needle decompression a bit, but just going over that again, there's a couple different needles on the market. The one that we carry is the ARS. There's also one made by H&H, and they're essentially the same thing, but it's a 14 gauge catheter that's 3 1/4 inches long. That catheter has, it's a thicker walled catheter that has some reinforcement kind of ribs on it. So, when you've done a chest decompression, sometimes that catheter can start to sort of accordion up as you're trying to go through the skin and the muscle. But this is a thicker walled catheter that is a little more hardy. But it's good, to always make just a small little nick in the skin right where you're going to make your incision. If you nick it with the needle, that helps to be able to slide that needle in a little smoother, without it catching on the skin. So our signs of a tension pneumothorax, we're all familiar with them, but tachycardia, increased work of breathing, difficulty breathing, and then dyspnea and absent lung sounds on one side. The tracheal deviation, that's kind of further down the road. Hopefully we don't let it get to that point if it's a tension pneumo that's developing in front of us. Everybody's probably familiar with the procedure. As far as placement goes, we do mid-clavicular line. We're not doing mid-axillary here in Clark County. You want to insert that needle in the second intercostal space. Remember to always go over the rib. Every rib has a artery, nerve, and vein that are running underneath it. So always kind of just roll over that rib. And then once in the thoracic cavity, the placement can be appreciated with that whoosh of air that we hear about. Another alternative way to confirm placement is you can take a 10 cc syringe and put 2 or 3 cc's of saline or sterile water in it and have that on the needle. Once you've placed the needle into the chest wall, you can remove the plunger on the catheter or on the syringe, and then as you insert it into the pleural space, that you can appreciate that placement a little more with bubbling in the water, and then it'll just kind of drain into the chest wall. And that's a good way to do it in the field where maybe we can't hear that whoosh of air or see it. I've never had the plunger pop up because there's so much pressure in there. But so that's just an alternative way. There's a little more setup to it, but it works really well seeing that bubble. If you're in the pleural space, you kind of get that pop in there and nothing happens within the syringe, what you can do is try to give it just a little bump with putting the plunger on, see if there's like a small blood clot or tissue piece that's occluding that needle and that catheter, and once you pop that through, then the fluid will drain into the chest wall. So it's kind of an effective way to appreciate placement, but it does take a little bit longer. Once you're in the pleural space, remove that needle and then advance the catheter until you meet resistance, and then we're just leaving that catheter in place and converting that tension pneumothorax to a simple pneumo. And you may need to repeat it, or you can try to put a syringe on with a little saline, bump that catheter again if it seems like that tension pneumo is starting to redevelop, or just do another one next to it. Pelvic fractures, the pelvis is a very stable ring, and this is a gentleman that I took a picture of. This was 11 days after the earthquake in Haiti. He was pulled from the rubble and brought to our field hospital. He had a pelvic fracture, and he had Coca-Cola within arm's reach of him while he was trapped for 11 days, and that kept him alive. Hardy people, and we just, that pelvis was stabilized in the field with like a sheet. But what we've found in the field, is stabilizing the pelvis with the sheet is kind of difficult, because every time we move those patients, that sheet tends to loosen. It's also difficult to, use the right amount of force to stabilize the pelvis, not tighten it too much or not enough. So there's a couple commercially made products that are available to stabilize the pelvis. It's just a really large bone ring, and we want to stabilize it like any bone to decrease pain. And then also what it does is it's gonna decrease blood loss through small vessels. So this isn't something that's going to control exsanguination within the pelvis by placing the pelvic sling, but it is going to decrease pain and decrease blood loss from small vessels. Pelvic fractures are associated with higher mortality, and most commonly due to hemorrhage. And unstable pelvic fractures need stabilization, especially, to sort of bring that structure back into its anatomical position, to reduce pain and then also help to reduce movement. What we carry, I believe District 6 carries this as well, is the SAM pelvic sling. And looking at all the studies that are out there, this seem to be the most effective pelvic sling that there is. And what it's doing is just stabilizing that ring, and it's got 2 springs inside the buckle, so as you tighten the straps, they kind of click into place when it's the right amount of force on that ring. And it provides circumferential compression around the pelvis and approximates the bone ends. It's designed to remain in place kind of long term till that patient can get to definitive care. And other than the 2 tiny little springs, it's radiotranslucent, so the patient can go into X-ray, and this isn't going to jack up that image. And it won't loosen on its own like the bed sheet will. So that's another benefit to it. There's really no documented contraindications to using a pelvic immobilizer device, other than if there's a hip fracture, hip dislocation, it's obviously going to really increase that pain if we start shoving that bone in against the pelvis, So that would be a relative contraindication. It's important to remove keys, whatever else, out of the pockets before you place this if you're placing it over the clothing. And then with any pelvic fracture, we really should limit our log roll to about 15 degrees. So we don't want to roll them all the way up onto their sides. The placement of the pelvic immobilizer is right at the level of the hips, at the greater trochanters. If we place the sling high up on the pelvis, then what that's going to essentially do is open the pelvis up. We don't want to do that. We want to stabilize it. So placement is really the big thing to make this device successful. So low on the hips. Sager traction splint, I believe that's the traction splint that everybody carries here in Clark County. And we also have a small splint that it's called the KTD, and it's kind of like a tent pole that extends out, and we have that for our technical rescue team just because it's so much more compact. But the benefit of the Sager is you know how much force you're applying to that muscle when you're pulling traction with it. Its indications are for proximal third and mid-shaft femur fractures, and contraindications are fractures of the pelvis or fracture dislocation to the hip, knee, ankle, or foot. If we have significant injuries to one of those joints, placing traction on that is going to increase that injury. And a misconception, I believe, is with open femur fractures a lot of people think that we can't put traction on an open femur fracture. And, you know, the benefit of placing traction on that injury, you know, it's going to control bleeding, it's going to reduce pain, and potentially reduce tissue damage from that bone end. And, you know, that's likely a grossly contaminated wound that's going to be irrigated in surgery quite a bit, and then the patient's going to be put on antibiotics. If you do have an exposed bone end, you know, from the femur, before you place traction, obviously irrigate it with saline, irrigate that wound and that bone in, try to remove those gross contaminants. But then you can place traction on that person just to reduce that pain and the bleeding that's associated with it. As far as placement goes, you know, you place the splint medial to the injured leg and extend until the crossbar is parallel with the patient's heel. And you can measure that based on the uninjured leg. You know, you're placing it where you want that thing to be. Use 10% of the patient's body weight, up to 7 kilos or 15 pounds for an adult on each leg, or 30 pounds for both legs. You can be used to immobilize both sides. And then with pediatrics, it's 7 pounds for each leg, or 15 pounds for both legs. Still using the 10% body weight rule of thumb. This is the Israeli bandage that we carry. It's out of the package. It's in a separate package, so you got to open it twice to get it open. It's got a large gauze pad on the other side, and so that sticker says place other side to the wound. You place that over the wound, and then your first 2 wraps are basically just to capture the bandage on either side of that of the pressure bar here. And then you run the bandage through that bar, and it gives you a change of direction. So as you pull it tight through that bar, it's going to put pressure down on the wound. And then you can continue to wrap. Anytime you're doing a compression bandage, another thing you can do is put a twist in the bandage over the wound as you wrap it, and that's going to add more pressure over that wound site. And then on the end of this thing, it's got a closure bar just with real aggressive teeth that will grab anywhere on that bandage. An alternative, you know, that you can do is you can use kind of the end of it as a sling, wrap it around the neck, and then capture that bandage. So it's kind of a nice tool to have. So that's kind of it for the trauma stuff. Real quick, I'm going to just introduce you to the special operations medical protocols that we have now. Very low frequency use on these, but these are really follow the national standards and essentially are the same protocols that are used in the whole Portland metro area for technical rescue. So they're just extended protocols that we have the availability to use, you know, when needed. So these are just for the technical rescue team medics, which is made up of Vancouver Fire and District 6, and we've had some extra training from Dr. Whitwer on these, and we're only going to be utilizing these protocols though when it's really a technical rescue team operation. So just because I'm a TRT medic doesn't mean that, you know, I can be using these on any call, you know, as I'm skating around day to day. So the protocols, the big ones and the ones we're going to talk about is advanced pain control and sedation during extrication, or, you know, during a very painful procedure, and then treatment of crush injury and crush syndrome. So again, these are just for the technical rescue team medics to use. For advanced pain control, when we need analgesia and sedation, we have the availability to use ketamine. So this would be a patient trapped under, you know, machinery or in a machinery or rubble, or significantly trapped in a vehicle, and extricating them is going to cause a lot of pain. Then we have the availability to use ketamine. Ketamine is a dissociative hypnotic, and it's got anesthetic and analgesic properties. At lower doses, it has pain management, you know, analgesia properties, and so a low dose ketamine is kind of the pain dose. And then higher dosages that, like at the level that we use for RSI, that's going to give that dissociative anesthesia, and really disconnects patients from from the reality. And so you can perform very painful procedures. And I've assisted with an amputation of a patient with just ketamine and Versed, and you know, without obvious signs of increased pain for them. It's got a really wide safety margin, especially in kids, and it's cardiorespiratory stable. So it's not going to decrease the blood pressure. It really increases the blood pressure and the respiratory rate for the most part. There's some emergence phenomenon that happens typically kind of in the middle dose when you're kind of in between low and high, and that's where they start having bad nightmares, you know, and you know, very vivid hallucinations, and that can be controlled with ketamine, or I'm sorry, Versed, thank you, with more ketamine. The nice thing about ketamine is you can't really overdose a patient with it. You know, once you get to that effective level where there's nystagmus, then you don't need to give more ketamine because you have effective dissociation. And it's pretty short acting, so you know, sometimes we have to give more, but it's been used a few times locally since we got this protocol with patients that, you know, fell up like around Dugan Falls and Naked Falls, and some of these patients had significant injuries, and it really facilitates, you know, when we've packaged these patients, moving them, you know, doing high angle rescues, that sort of thing, or extrication, you know, where there's significant entrapment, you know, it can really help in that area as well. With crush injury, crush syndrome, this is a protocol that we have availability to use if we have a patient that's been crushed, you know, and with crush injury, that's really can just be smashing your thumb with a hammer, or it can be having a large piece of machinery fall on top of you or a structure fall on top of you. And what happens when there's tissue damage is when a cell is injured or damaged, its wall becomes really weak and it will lose its contents. And those are toxins that then get into the bloodstream. And with entrapment, once we release that compression force, then all of those toxins are reintroduced into circulation, and that's when we get those problems with you know, kidney and heart very quickly, and they can rapidly deteriorate to death. You know, so we have the availability to you know, following the hyperkalemia protocol if they have signs of that, but then doing some other kind of pre-treatments before we remove that compression force. So, you know, obviously airway and oxygen is a big thing, IV access, and then pain management and sedation. This would be a good time for us to use the ketamine to sedate that patient. And it's, you know, with ketamine, you can even do kind of dream planning is what it's called, and basically tell this person what they should be thinking about before you give the ketamine, and it's pretty amazing how well that works for them. If you're a nice person and your dream that you planned for them was a good trip. So, you know, it's a really effective drug and very helpful, you know, in that situation. I want you to dream that you're not trapped right here. And then bleeding control, if we can't address that hemorrhage at its source, obviously, because of the entrapment and just access, then we're going to place tourniquets for that. And then spinal mobilization, splinting, pelvic stabilization considerations is needed. And, you know, dusty environments, hypothermia prevention early on, those are all really important. And then what we're going to do is we're going to administer 1 to 2 liters of saline, give them this large bolus, and then we're going to decrease that and maintain it at 500 cc's per hour to really dilute all of those toxins. And then a sodium bicarb infusion of 125 milliliters per hour. And something else we can do is begin to give a bolus right before that compression force is removed to sort of help as that force is removed. We're trying to stabilize the heart, you know, as those toxins are reintroduced into circulation. And then, you know, we have the availability to request a trauma surgeon to the scene. That's something that Dr. Whitwer and Mark have been kind of working through, just the logistics of that, of getting a doctor, you know, and with the right equipment out to the scene if that was something that was needed. I can find like 26 cases nationally where that's happened in like the last 20 years in the normal pre-hospital environment, not, you know, following an earthquake or large tornado or something. So it's not something that's real common, but obviously it's a good thing to have a plan for in case we're ever put in that situation where we, you know, where we need access to a trauma surgeon. So that is about it. Are there any questions? Yes. Yep. And that would be separate from like the hyperkalemia protocol.
If you were ever to have the need for a surgeon for a pre-hospital amputated stuff, you've got a machinery, a machine or a structure that's too heavy to lift under the existing, too long to bring it in. The patient's going to deteriorate in that time. Call medical control. Ask for the trauma surgeon on call. Relay that, and they will then arrange to send either another trauma surgeon or more than likely because that. Come on as we go along with the case reviews today, many of which have some trauma source, is that, okay, bleeding control is a big deal. Although most of it's within the capability of paramedics. We're going to be training to bleeding control next month, including wound packing, because you haven't had any practice with that. And there is a technique to it that we'll teach you, that you just don't stuff it into the wound. You sort of have to layer this in. It's like when I started, when we're working in the ED, it takes a while to teach a doc how to put in nasal packing. Sometimes it's really, you know, they end up stuffing it in, and then you don't get anything in there really, and it doesn't actually pack the wound. So you have to layer it in layers. And wound packing, believe it or not, and most of you, I can put 72 inches of 1-inch gauze in your nose to stop a nosebleed. But there's a technique you have to learn how to, you know, and you can't just stuff it in with your finger. Although your finger is what probably caused the nosebleed in the first place. So, now, tourniquets. There's a big push. The trauma surgeons who haven't had any experience in military or very little are really pushing the idea that everyone should have a tourniquet and be able to put on a tourniquet. Now, it partly happened after the Boston Marathon bombing. You know, most of the time we don't have mass casualties involving a lot of bleeding in the United States because we don't have a lot of bombings at this point. A lot of IEDs going off. What they did, the first blush after the Boston Marathon was that, oh, all the locals who did good Samaritan stuff and put on homemade tourniquets, they took off their running shirt and they wrapped them around, they did all these things. They said, oh, they saved all these people. Well, in the actual wrap-up of this, they found out that almost every single one that was put on caused more harm than good because they weren't real tourniquets. What they did was increase venous bleeding and didn't do anything for the arterial bleeding because they weren't tight enough. They weren't cat tourniquets. They weren't military applied type of tourniquets. So now they're pushing that, of course, you have real tourniquets available, but I think having a pack of real tourniquets available in the airport next to the AED is kind of a waste, more than likely. So it gets to Joe's thing. When you get there and you have someone, a bystander put a tourniquet on somebody, made a tourniquet up his belt or whatever it is. When you put your own tourniquet on, you can take off that other tourniquet. Or put your tourniquet on, get it ready to put on, and then unapply the other tourniquet and see what happens. Because likely, most wounds we have, pressure, just direct pressure will take care of it. Most of the ones we're used to. Now, gets into the other end of the thing. Just at a meeting in Louisville, and one of the persons who's been very big on the bleeding control stuff, but he's also a person of good common sense, has done a review of active shooter in the United States. And of all the active shooter cases that have occurred in the United States, lots of people, including the most recent one in Oregon, less than 1%, which is essentially none, of the wounds sustained by the victims were amenable to external hemorrhage control by tourniquet. Because what are people, when in active shooters, where are they shot? Shot in the head or shot in the chest? Can't put a tourniquet on the head. We can, but it doesn't really help. So, keep that in mind, that tourniquets are good, and now, when we go today, we will have a few discussions of that. So, before I get going on trauma, okay, ALPS is done. Yes, okay. So no longer do you, I know you guys are gonna really miss that little clear link adapter. You can't keep them, you can't store, you can keep one for posterity, I suppose, but ALPS is done, and so now we go back to our original protocol until we find out what the results of ALPS are. Now, people say, when are we going to find out? Okay. They're crunching numbers right now, and the dreamers in our group of researchers say, well, we'll have some results by December, into December. Nah. I'm on one of the writing groups, which is going to be writing up the results of this, and it's already been contracted that the JAMA, Journal of American Medical Association, wants this article, and they want this article by middle of April. So it's unlikely that the results are going to be out much before that. And there's another trick. When you have an article, the rule in writing papers is that you can't tell anybody the result of the paper before you publish the paper. So we're looking at April before we get the definitive answers. But if I find out which arm is the best one, we'll sneak the answers to you in the form of, I won't tell you, I'll just put it in protocol. So, okay, so standard therapy. Standard therapy for cardiac arrest is your usual epinephrine doses every 3 to 5 minutes. And for VF or VFib, if it persists, in other words, when you get to the point where you would have used ALP, so you've had two shocks given to VFib or pulseless VTAC, then we're going to go to amiodarone. And the dose for amiodarone is 300 milligrams IV or IO, and repeat it times 1 at 150 milligrams IV IO in 3 to 5 minutes if you still have persisting VFib VTAC. And no difference. Now, if for some reason amiodarone is contraindicated, we do have lidocaine, standard dosage. And if you have torsades, of course, we're going to use magnesium. Probably preferable to using magnesium before you would use the amiodarone. Okay, first case. Code 3 for traumatic injury. 27-year-old, 110 kilogram, ambulating toward MICU, covering a neck wound with his right hand with continuous bleeding noted from the neck wound. Keeps saying, am I going to die? It won't stop bleeding. Complained of difficulty breathing. While speaking to EMS, there was notable air release from the neck wound. As a matter of fact, one of the persons said, I think I see his trachea in there. Loaded to the gurney, transported code 3 to P South Southwest. Moved his hand from the wound, and then he coughed. That made him cough, stimulated that trachea a little bit, and he sprayed blood over it. So I'm certainly glad everybody had their personal protective gear on. Then applied direct pressure over the trachea with a gloved hand, occluded the hole, applied pressure over the arterial bleed with the trauma dressing. Now, there's an advantage to this person. He's young, in his 20s. So he's got 2 carotids, 2 intact carotids. One is not intact, apparently. And he could answer all questions. He said, quote, a firework came out of the wrong end of the launching device, hit him in the throat when it exploded. Well, what don't we believe about that? But that's another story. So, at any rate, he has a laceration type injury of his neck and a number of other things. His pulse is 120. Blood pressure was says not taken. I'm not sure entirely why, because you had enough people there. Respiratory rate's 26, quite anxious. Not able to obtain any blood pressure during transport. I don't know if he means he didn't have a radial pulse, didn't have a brachial pulse, just it's not recorded. I think maybe they're anxious at that point. Got vascular access, gave him a little fluids. Oxygen, pulse oximetry was 85% on room air. Pulse 122, respirations 24. So He was in the hospital for about 16 days. ED physician intubated the patient without difficulty. Several bleeding veins ligated in the ED, but taken to the OR. Cricothyroid membrane, external jugular, and several right arm lacerations, right triceps laceration were repaired. He had difficulty coming off the vent, interestingly enough, required a tracheostomy. Injuries appeared to be consistent with stab wounds rather than blast injury. Neck and arm wounds had no evidence of stippling, no tissue injury that would have been, I mean, fireworks explodes on you, you get gunpowder, right? You get residue. He ultimately improved with steroids and antibiotics. He was alcohol dependent, go figure, and had withdrawal symptoms. EMS crew did a great job of managing this patient. In retrospect, and at a further discussions with the patient, this was basically a homemade explosive device. It was an IED. Though I think many of his problems are still to come. Because, the ATF doesn't take kindly to that. But I'm not sure where that'll go. But at any rate, it was metal that exploded that hit him in the neck and did lacerations. It wasn't a fireworks. Oh, we have pretty pictures in this one. Is it okay to take pictures at the scene? Yes, as long as they don't reside in your, as long as they don't reside in your personal camera, and you take, and they're selfies, and here's a picture of me with this wrecked car behind me, and that we don't post them on Facebook. This comes in real nice to get these kind of things. This is a two-car, head-on, high mechanism MVA. Driver is in a full-size truck, hit another full-size truck. As you can see, there's significant damage, airbags and everything. Patient was entrapped, needed heavy extrication. Extrication is going to exceed 30 minutes. Legs were trapped underneath, the feet were trapped underneath the pedals, everything was crushed in there. You can see everything is sort of moved back into the patient compartment, into the passenger and driver compartment. Was a nice truck. During extrication, patient's conscious alert time 4, had several beers, doesn't remember the accident, complains of leg pain, has serious bleeding from an open deformity to the upper left leg. 30 minutes to extricate the patient, so they place a tourniquet appropriately on the leg. Can't assess distal neurologic assessment at that point, but 30 minutes of even, moderate bleeding from an open wound is going to be, a lot. You can't really effectively get in pressure dressing. So, pulse is 110. Pulse taken at the radial, so we have to assume that his blood pressure is at least in the 70 to, at least in the 90 range. IV started. Now, this is the prolonged extrication, and the medic there was trained to this, and so they elected to use ketamine for pain control and sedation during extrication. Half an hour of jacking things around and taking this guy's legs out from underneath the thing. Now, theoretically, ketamine may be the drug of choice to use in trauma cases, particularly if you're worried about blood pressure, because it, intravenous narcotics, intravenous Valium will drop your pressure a bit. So if the patient were hypotensive, ketamine might be the drug of choice for that because it won't do that effect. It does improve ventilation by itself. It's not ready for prime time yet, so we do have it trained. We do have it trained for the TRTs, but I'm not yet ready to release it for prime time because all the studies show it works fine, and it decreases the need for narcotics, and most of the studies have been doing a kind of a silly test. They've been giving narcotic, and then the other arm of the study is narcotic with a low dose of ketamine, and they need less narcotics. Big surprise, and they get the same pain relief. Problem is that's not a very good side-by-side study. It should be either ketamine or narcotic. And then to see, now, the thing is, the narcotic ketamine arm have a lot more complications, mostly weird dreams, but there's also associated with increased mucus production, in particular in younger people, and have some respiratory stridor, which is mostly due to mucus more than anything else. So, I mean, there are some things still to be worked out on this. So, we'll have more news at 11. Besides, Mark says we can't do another protocol change for a few months. Right, see, and I know I do what I'm told. So, yeah. He has a nasal NPA placed, and nasal NPAs work really well. It's really nice for the patient if we have lidocaine gel to sort of put on that too, because it numbs up the nose a little bit. But an NPA is very safe, and I think a soft, flexible NPA is almost impossible to shove into somebody's brain through the cribriform plate. Unless the guy's face is moving around all over the place and you think he has a Lefort 3 fracture, I don't think there'd be any problem. And he did well with the NPA. Pulse comes down a little bit, 104. He got a lot of relief from his pain, and they couldn't obtain a pedal pulse in his left foot. Also, when they extricated him, they couldn't either. He had some right-sided chest discomfort, no crepitus, no deformity, and that's not. We translate this directly out of the charts. It transported code 2 to P-South Southwest. I don't know what that means because there is no code 2 transport around here, so we assume he went code 1. Okay, on arrival, he didn't have code 3. Code 3. On arrival, patient without a Doppler, it says Dopplerable. He had no pulse on Doppler. I don't think Dopplerable is a word, but we'll put it anyway. He had no pulse in the left lower extremity. However, when they reduced his fractured foot and ankle, he did have pulses. So he had a lot of things. Splenic lac with an open wound into peritoneal cavity, had left pulmonary contusion, open left femur fracture where that tourniquet went on. Multiple fractures of the left foot is what's called a Lisfranc, name for a French surgeon in the Napoleonic War who described the mid-foot fracture dislocations. It's a terrible injury because unless it's fixed, and fixed surgically, they end up usually not being able to walk normally ever. because it destroys the ligamentous arch support. At any rate, it requires lots of surgeries to fix that. Had multiple left rib fractures, right foot fracture, lumbar fracture, distal ulnar fracture. He's not done getting fixed yet, but he had good, I mean, that's a very complicated, it was very complicated extrication. He did very well with that. He was well taken care of and delivered to the appropriate trauma center to get fixed. Now, case 3, another trauma. 2-vehicle crash, cab over semi, rear end of the flatbed semi. High rate of speed. This is out in the Woodland kind of area. I-5 Woodland. Seatbelted driver, cab over with heavy damage, significant intrusion into the driver's compartment. Patient pinned in by the dash and firewall, crushing his legs. This required really heavy extrication. Matter of fact, they felt it was going to be more than 30 minutes. Patient responded to painful stimuli only. Physical assessment showed he had multiple lacerations of his face. Lower lip was torn from the lip to the chin, is it through and through. Teeth, say, amputated, you're just missing teeth. Is bleeding from his mouth, lip, tongue, teeth, possible pelvic fracture, right leg, open fracture of the femur, patella, and ankle. Matter of fact, one medic who looked at it felt that this was a near amputation. Pulse was 140, blood pressure apparently could not begin. Weak pulse was found at the carotid. Respiratory rates only 20, shallow. As IV running, he's gotten a total of in the total experience in the field, they had 2,500 cc's of fluid given to him and something else more to come. His GCS was about 10. And as they're trying to extricate him, so life flight was called early. Life flight landed at the, because of the prolonged extrication, life flight landed at the Woodland Airport and were transported by one of the fire vehicles to the scene. And they brought blood with them. So they start blood in this, at the scene. And because now life flight's on call or on the scene, you've got life flight medic, life flight nurse, and they call for ketamine for RSI because patient's hypotensive. That's their orders then for hypotensive RSI. They're going to use ketamine as the sedative, which you can do too. It's in your orders. And then they intubate him with rocuronium. I asked the life flight medical director why rocuronium. He says that's what we carry now. It's the only thing they carry. They don't carry succinylcholine apparently. So they intubated with rocuronium, which is going to give him a paralysis for a minimum of 60 minutes. And apparently no real problem. Oh no, they did. They had 2 attempts to intubate. 3 attempts to intubate. And finally got him intubated with the glide scope. CO2 is 50, waveform was okay, and anyway, on and on and on. Now, they gave him some more ketamine for sedation when they felt he was awakening from this. You know, his life flight is sort of in charge of this all the way along here. And no. No. And this is and we are in the midst of a long discussion with Life Flight about this case, because if you follow, and I'm not going to go through point by point, but here's the key things. At 9:08, we got to the land, our crew got the patient to the landing zone. Was semi-comatose. They tried three attempts to intubate, and at 9:27, count that, it's 21 minutes, they moved the patient from the ambulance, loaded them onto the helicopter. The helicopter engines were not running. Oh, surprise. Yeah. So, but because Life Flight crew had been transported there, they continued that, which is, I think, appropriate. But there's yeah, the patient would have been at Southwest before, probably before they took off. Now, where'd they go? For some reason, they went to Emmanuel. And we cannot quite nail that down, whose decision that was. Now, partly, we have a partial answer, is that one of the medics did call the ED physician at Southwest and say, we have an amputation. And they said, an amputation of the leg. And he said, well, if there's an amputation of the leg, you should take them to Emmanuel today, because that's probably where they're going to be able to put a leg back on or do something about it. Incidentally, when people have traumatic amputation of the legs, they don't generally put them back on, generally. But it turns out it wasn't an amputation of the leg, just an open fracture. And he had other fractures. But, you know, this was, you know, kind of, in one sense, you know, I wouldn't be upset with you guys if you took 3 attempts to intubate a difficult patient, as long as you got it. But I would be upset if you sat around unseen for half an hour before you drove the ambulance away. So this guy, we don't know everything. We know he's alive. He knows a little bit, but I'm not sure he knows a little bit about this. Here, talk to this.
So the point, talking. Hello, Mom. That's an old joke. We won't. So, anyways, the point is, in the extricating medic relays to the Life Flight medic, we have a possible amputation. So the Life Flight medic takes it upon himself to call PCEP Southwest and say, we have a possible amputation, and of course the ER docket, PCEP says, go to Emmanuel. Well, this was probably, the time frame was about 45 minutes by the time they got into the helicopter and started to fly away. So the point of the whole thing is, number one, it's the on-scene medic's responsibility to determine destination. Lifelight's there, they're just a vehicle for you.
They're an ambulance.
Yeah, they're helping you, essentially. So that was where one of the issues broke down. The other issue is that I think there was a little bit of preconception about what the best place for this patient was, but that's, I'm speculating. So.
And you probably shouldn't talk to medical control until you get the patient extricated and figure out what's really wrong with them. You know, when they got him out, they said, oh, you know, there's no amputation here. He's got an open, probably an open fracture of his femur. Simple. All right. This has been well, they still can take over control, but that doesn't mean destination.
It's up to us on scene. Whoever the PIC is, incident commander, depending on the type of scene, it's up to us to determine where he goes.
Yep. Yep.
That's our job. They're just a transport vehicle.
So when the medic in charge of extrication and then the initial evaluation of the patient should have said, okay, this patient, we've been sitting here now for 30 minutes to get him out of here, so yes, let's fly him, but he needs to go to Southwest, and they would have made the contact to Southwest at that point, telling him what you had. I mean, how many times do you call Southwest when you've got a patient still in a car and say, oh, I think I've got this? You don't. How many times you contact medical control until you have some sort of vague idea? We stopped calling medical control at Southwest years ago when we were on the way to the scene to find out if they were, quote, up for trauma. They're always up for trauma now. So, okay, this is we had really tremendous amount of trauma in the last month and a half. You guys may have noticed. Per cousin on scene, he was driving with the patient in the car. She became agitated for an unknown reason. Told him to slow down so she'd get out of the car. While the car was still in motion, she jumped out of the moving car on a bridge and then jumped from the bridge to the railroad tracks below. They estimated at the scene about 100 to 150 feet. Well, it's not quite that far. She has a past history of depression, anxiety, psychosis, allergic to penicillin, taking some thyroid medication. That's probably too much from the looks of that. Patient prone in gravel near tracks under the slough bridge, GCS 4, 2, 5, or 11. Amazing. So no apparent injury of the head, airway clear, patient moaning, neck and spine deformity, left posterior back with abrasions throughout, tenderness left side of the abdomen, left upper extremity deformity of the arm, remainder of exam unremarkable except for abrasions. This is under the Camas Slough Bridge near the railroad tracks. The RP showed the location of the patient over the steep high angle embankment under bridge. Reach and treat bag with belay line, and went down and made contact with the patient. Found patient in the condition we described, notified BNSF, you know, stop the train. So IV, blood pressure 110, pulse 140, respiration 28. I'd like you to note that a blood pressure and pulse was taken on this patient. Full spinal precautions, coordinated to transport by the rescue team truck to rendezvous at west end of the mill. There's the big mill out there, Camas. Code 3 trauma system of Peace South Southwest. IO placed in right leg. By the way, where do you, in trauma, the trauma docs are really liking IO placed in the humeral head. They really like that. Full trauma alert. Blood pressure now 135 over 97, pulse 150. Now, she did not do well. As the ME had the final decision on this case, she had an atlanto-occipital operations, although the ME said that's not the worst thing. It's obviously the neck fractures and cervical spine injuries. So, but a very difficult reach and treat, and and quite a difficult extrication patient. Case number 5, unknown problem, man down. State Park Ranger drove upon the scene doing his nightly patrol and found a guy underneath the I-5 bridge. Main gates part open, he's laying in the grass, and this comes right out of the dispatch notes. Then they lose connection. RP originally said not sure if he fell from the bridge or what, so they've done a CCSO and a medical response. Non-responsive breathing, laying weirdly, looks like he fell off the I-5 bridge or he jumped. Okay, now they say, oh, he did come off the bridge, has a leg fracture, breathing but not responding, white male, transient in his 50s. I don't know how they established the transient part necessarily. 7 by, okay, compound fracture to both legs, maybe calling WSP, definitely came off the bridge, don't know if he jumped or was hit, on and on and on. So, 52-year-old, about 100-kilo person, unconscious, responsive only, painful stimuli, lying supine on the ground, obvious deformities of both legs, appeared to have fallen off the I-5. It's about 75 to 100 feet at that point. Skin cool, pale, dry, no deformities noted to the head, no obvious abnormalities of the neck, back clear, chest clear, lung sounds not assessed, don't know why. Arms, deformity noted left wrist, possible fracture, abdomen soft, non-tender, pelvis stable, compound femur fractures bilaterally without bleeding, without active bleeding, except at the end of the right femur after placement in normal anatomical position. AMR puts a tourniquet on. Okay, good. You've got a lot of other things to attend to at that point. Blood pressure 128, maybe palpated, pulse 116, assisted ventilation, I don't see that they intubated the patient. Oh, yes, here we go. Etomidate and intubation, 1 for 1. Capnography is good. CO2 value is 29. CO2 rises a little bit. Got some midazolam for sedation. GCS, of course, paralyzed is now 3. Vital signs 104 over 74, pulse 97. I can live with that. CO2 is still a little low. Probably, it says respiratory rate 14, but they're probably hyperventilating him a little bit inadvertently. Patient is probably why they thought he was a transient patient. Fire removed large amounts of clothing from patient to get to him. Obvious deformities to lower extremities, had uncontrolled bleeding from the right open femur, applied tourniquet with good result. Code 3 to intubated, full C-spine, transported to Peace House Southwest. In hospital, bilateral open femur fractures, left distal radial ulnar fracture, multiple rib fractures, left side, subarachnoid hemorrhage, subdural hemorrhage on the right side, and orbital fracture. He was ultimately transferred to a manual for management of his femur fractures, because the trauma orthopedist was in a 3-hour procedure at that time. But so he was stabilized at Southwest and transferred for definitive. Now, I haven't heard how he's done since, but obviously the subdural subarachnoid was not of significant amount to take him to the operating room for that. He probably had a chest tube placed for his rib fractures on the left side, considering he'd be on a ventilator for a while. Okay, a mention of our C-spine protocol, just because it has come up repeatedly in trauma meetings at the hospital, and I'm tired of dealing with the trauma surgeons on this issue, which should not be an issue. For C-spine precautions, we're allowing you to do C-spine with C-collar and immobilization to the gurney for people who are ambulatory at the scene, people who have long transport, interfacility transport, and patients where a long backboard isn't otherwise indicated. We don't think a long backboard is necessary for everybody. However, minimizing movement and attention to spinal precaution is still paramount. And here's the salient thing. Your note at the bottom of this says, all patients who meet trauma system activation criteria. So anyone that you call a full trauma team on, or anyone you call a modified trauma team on, due to blunt trauma mechanisms, will have at the minimum a cervical collar in place, and they will be immobilized to the gurney in a supine position. Not sitting up, not in semi-Fowler, unless there is a contraindication for laying supine. And the contraindications include respiratory distress in older persons, respiratory distress in fat people who can't lay down, or in people who have kyphosis, scoliosis, emphysema, etc., who have difficulty laying flat on their back. Beyond that, there's almost no reason. There's a couple of other reasons I could think of, and but you need to tell the trauma surgeon or the trauma person when you bring them in why they are sitting semi-supine. We had a patient, a likely candidate the other day, who had a head injury, turned out to have a skull fracture actually, and had a bad headache, and the headache, and she was walking around at the scene. It was a athletic thing, and she was walking around at the scene, and when she laid down, the headache got worse. You know, in many cases, you know, when we're dealing with people who have increased intracranial pressure, it's not uncommon if their C-spine has been cleared that we will put them in a, you know, in a semi-Fowler position, head up a little bit, and with increased intracranial pressure, we prefer to transport them in a head up position slightly. But their C-spines have been cleared generally at that point. C-spine is not cleared, they should be laying down. She was not complaining that much. Now, if possible on the gurney, you don't have to sit them up. What you can do is raise the head of the gurney, have them on an angle. But when you bring them in as a trauma team or modified trauma thing, they have to have a C-collar, and they're supposed to be brought in supine, secured to the gurney supine. Now, you can say, well, God, you know, a lot of these people don't. Well, then don't make them trauma teams or modified trauma alerts. I mean, why do we have to call every person who fell down and bumped themselves a trauma alert? You know, if they're if it's a 6-year-old who bumped into something and they ran across the parking lot to their mother, they're probably not significantly injured. One of my partners years ago said, hey, would you help me sedate this child who needs a CAT scan because he has a head injury? And I said, where is this child that we need to be sedated? And he said, well, he's running down the hall right now. I said, I don't think this kid has a significant head injury. You know, sedate. So, secure them, supine, C-collar, bring him in, keep those trauma surgeons happy. We cannot teach old docs new tricks easily. Yeah, get them to stop bitching at me. Okay, we don't have ALPS. Just to remind AMR that we still have the SUD study going on. SUD study, sudden unexpected death study, we need a blood sample. So now when you go to the scene of anybody who has a pre-hospital cardiac arrest and you're not even thinking about the rock anymore, when you start that IV, try to, if you can think to grab a blood sample, so much the better. Even if you get ROSC, it's even better if you get RSC. So, because these are genetic studies we're doing. So, and all you do is label the tube, EMS number, date of service, put it in the baggie, put it in your cooler, and then transfer it to the refrigerator at AMR Central. Okay, any questions? Thank you. Have a good Thanksgiving. And next month is trauma practice. Tourniquets and things. And I'm thinking maybe nasal cannulas too. No nasal.